I think now we're going to transition over to a final question and answer period. So I'd like Dr. Hallett and Dr. Richardson. Dr. Jankovic, I think I have a cab waiting for you at 2:55. Yeah.
After final Q&A, needs to run the evaluation.
Yes. I'm going to say that right now.
To announce next year.
Okay. So before I say goodbye to Dr. Jankovic, let me just say a couple of things. If you would please turn in your evaluation forms at the registration table, that really helps the organization make the program better each year. You know, this year I asked Mary Lou if she would please send those to me, and she and I sat down together and looked at what patients liked, didn't like, and tried to develop a program. And then, you know, asked for some input from some others, and I'm sure the other directors do that in prior years. So it's, you know, really helpful. Furthermore, thank you. Furthermore, I wanted to announce that next year's symposium will be Saturday, August 1st in New Orleans. And that's it. Now we will start the Q&A in just a minute. Okay, well, here's a kind of very general question. This one is for Dr. Hallett. Dr. Hallett, what is the total number of blepharospasm patients worldwide?
Oh, beats me.
Plus or minus 3.
Okay. Are there any...
Well, actually, I mean, the numbers really aren't that well known. There are a number of epidemiological surveys, but the quality of them varies, and it does appear to be different in different countries. And not all people go to see doctors about this, and some people have the problem and don't actually report it. So the information really isn't completely that clear. Yes, it is much more common in Asia, and the exact reason for that is not clear. There may be something about the anatomy of the skull. We were talking about that yesterday, but no one really knows for sure the reason that's the case.
Dr. Jankovic, what alternative therapies have you found helpful in your patient population? You're almost off the. You're almost off the.
Last one.
The question was what
alternative therapies, if any, have you found helpful in your patients?
Besides botulinum toxin and
yes,
microvascular decompression?
Yeah.
Well, I mentioned 3 drugs, carbamazepine, clonazepam, and baclofen. Those are the 3 drugs we used to use before botulinum toxin of the patient, if the patient was not a candidate for surgery. So those are
we're talking in general. I think they're talking about blepharospasm.
Oh, I see.
Yeah.
Okay. So, yeah, I thought we were talking about hemifacial spasm. So, yeah, we didn't have a chance to talk about medical treatment of botulinum toxin. And before the advent of botulinum toxin, medical treatment of blepharospasm. So medical treatment before botulinum toxin consisted mainly of drugs like trihexyphenidyl. Somebody mentioned, actually one of your patients in a video used the drug Artane or trihexyphenidyl, which was the drug that we most frequently used. I also in my talk mentioned the drug tetrabenazine, and one of your patients mentioned Xenazine, which is the brand name for tetrabenazine. This is a particularly useful drug in patients with tardive blepharospasm, but occasionally may be helpful for idiopathic blepharospasm. It's very helpful for patients with tardive dyskinesia, Huntington disease, Tourette syndrome, but occasionally can be also helpful for focal dystonia like blepharospasm. There are really not too many medical treatments. Most patients require botulinum toxin treatment or possibly surgery.
Okay. We're not going to talk about hemifacial spasms. There's just not enough people. If anybody has a question, please, we can talk about it later. I'll stay as long. But Dr. Hallett, anything to add to that in terms of alternative therapies?
Not really. I suppose the issues are medical therapy, botulinum toxin therapy, and then I suppose consider of non-medical, non-surgical things that people do get involved with, things like biofeedback and relaxation therapies and things of that sort.
That was one of the questions that I
Yeah.
wanted to dovetail here. They said there's an interest in the patient community to try various eye muscle exercises and conscious responses to spasms as a way to reverse brain plasticity. Does the panel have any views on the prospects for this or similar approaches?
Well, I suppose there's two separate issues there. One are these things like biofeedback, relaxation therapy, and so on. And I think that decreasing stress to some extent does help, and people do feel better in that circumstance. That would be a sort of a symptomatic way of looking at it. As we were talking about before, stress is bad for almost everything, and I think that if you can reduce stress, it will improve blepharospasm, as it will almost improve everything. Now, in terms of exercises to actually treat the blepharospasm by altering plasticity, that is another type of approach, and we did talk about that a little bit before. There may be sort of ways of doing that, but there's not a lot of research on that at the present time, and exactly what would be the best way to do it isn't clear either. So that is something that may be something for the future, but not really now. Craig, do you want to comment on that either?
I think you summed it up very, very well.
Yeah, okay.
Mark, the public is generally familiar with Parkinson's disease but has almost no awareness of dystonia. Can the results of Parkinson's research be used to increase awareness for dystonia?
Well, I think awareness of dystonia has improved considerably in the last maybe 15 years or so. It is true that prior to that, probably no one even knew what the particular disorder was, and we had a very hard time. Actually, Mattie Lou, when she was running the BEBRF, didn't like the concept that it was dystonia, and she used to say, "You're not going to use the D word." She used to say that all the time. But I think that and in the beginning, so there wasn't a complete recognition even that blepharospasm was a form of dystonia. So there has been a certain amount of confusion in this area. But I think dystonia is increasing in terms of awareness. There have been a number of spokesmen that have increased the knowledge about dystonia, and people are becoming more aware of it. The Parkinson community and the dystonia community are different. I don't think the people in the Parkinson community are trying to increase the awareness of dystonia, although it is the case that there are overlaps. Patients that have Parkinson's disease may have a little bit of dystonia also. This is one of the features of Parkinson's disease. So I think the situation about the public awareness of dystonia is improving.
Dr. Evinger, in your work, have you found that blepharospasm compromises one's, I'm just reading these as they come, compromises one's immune system so that one is more susceptible to viruses like colds, flus, etc.?
I actually don't have any information on that point at all. Perhaps Dr. Hallett does.
I don't think there's any evidence for that at all. Someone asked me in the break about a possible immunological cause of blepharospasm, and there's no evidence for that either. There isn't any particular interaction between the immune system and the system that causes these motor disturbances. So I don't think it either predisposes to infectious disease or is caused by any sort of inflammatory system.
Dr. Richardson, I have two here in a row for you that are not easy. Can a, quote, sensory trick, end of quote, be a deafferentation due to a sensory integration problem of the trigeminal nerve?
You're giving that to me?
Can a sensory trick be a deafferentation problem due to a sensory integration problem of the trigeminal nerve? Why don't you at least just give your thoughts about the sensory tricks and how they...
The sensory trick is very interesting. If you saw in the one video that I showed, the patient grabs his jaw to try to control his speaking, and we've thought about trying to record from the brain during DBS while patients do the sensory trick to see if we can try to figure out what the electrophysiological mechanism might be, but that's difficult to do in DBS surgery with the frame on. The idea of sensory integration, though there's no doubt we need to figure out how to look into this. And I think it kind of dovetails into the question about Parkinson's disease and dystonia. Patients who undergo these procedures that agree to contribute to research studies, or who don't undergo a procedure and do a functional imaging study, for instance, really are the people that are laying the foundation for potential advances in disease. These are major contributions that patients make to research, and the studies that Dr. Evinger showed are remarkable, but at some point need to be validated one way or another in patients, and the only way we can do that is through research as a part of treatment. So I guess I'll just say, if you have participated in research, or if you ever do, I thank you for that. And I think there are a lot of overlapping studies, for instance, in deep brain stimulation, that compare patients with Parkinson's disease to those with dystonia. And I think the more that happens, the more people may become aware of dystonia and its similarities and differences to Parkinson's disease.
Dr. Richards, I think you this may have come before
Sorry,
your talk. Yeah, go ahead.
Sorry, let me just comment about sensory trick, because it's a very difficult matter. We have been trying to understand sensory trick for years, and have done a number of studies, most of which have not been clarifying. Recently, we have looked over the world's literature in this regard and published a paper about this situation. And there is a little bit of evidence, only a little bit, that a sensory trick will rebalance the inhibition facilitation situation as regards to control of dystonic muscles. Remember, I was saying that there's a loss of inhibition. What that means is that there is not a balance of excitation and inhibition, that there's less inhibition, more facilitation thereby. There is some evidence that a sensory trick will decrease the amount of facilitation. So if you decrease the amount of facilitation, that will help rebalance the system, and that may be how it works. The amount of evidence for that is very small, but at least there's a little bit of evidence for that mechanism as working the way that sensory trick works. I think clearly a lot more work is needed in that regard. I wonder whether Craig has any ideas about it, because this is something that may be amenable through animal models too.
Yeah, I mean, I think much like Dr. Hallett, that's exactly what's happening, is that you're rebalancing the sort of inhibition and excitation within various systems. And once that happens, then, it suppresses sort of the unwanted movements. We've thought a little bit about this in animal models and haven't quite come up with an effective way to look at it yet, but it is something we're thinking about.
Okay, I have probably one question for Dr. Richardson, then Dr. Evinger, then Dr. Hallett, and that may be it. So, Dr. Richardson, I think this may have come before your talk, but the question is, are you actively recruiting patients for craniocervical dystonia, or are you still just considering this treatment?
Yeah, right. So we saw two patient examples. So Under the approval that was given by the FDA for the treatment of dystonia with deep brain stimulation, through the humanitarian device exemption, an institution like the University of Pittsburgh has to have a protocol in place with the local IRB. That's a group that overlooks studies like this. So, yes, we do this, and we've actively recruited in this area.
There's two.
Do you want to comment specifically on whether you would consider operating on pure blepharospasm?
Oh, that's a good question. I was going to ask your opinion on this, so I hope that you'll give us. And Dr. Sekula and I have talked about this a little bit. You know, he pointed out this concept of a unilateral facial dystonia that looks a lot like hemifacial spasm, but isn't. But that's a separate entity than what you're asking about. And I think the question comes down to how similar, let's call it standalone blepharospasm is to blepharospasm that involves facial muscles, jaw, etc. We know it's a dystonia. If you look across studies, there are rare reports of blepharospasm getting worse, actually, with deep brain stimulation, so that's a possibility for craniocervical dystonia. But as far as I know, no one has done this in a study. We would be interested in doing that. I think we have to think about it a little further. But a question for you, why do you think that hasn't been done before?
Well, I guess there's two issues here. Why hasn't it been done? I think that DBS in general is taken on for pretty severe problems, and in general it's been thought that since blepharospasm is largely controllable in other ways, that most of the patients are not really suitable for it. However, it's clear that some patients are not well controlled.
Can I stop you for a minute, Dr. Hallett? How many patients in the room with blepharospasm do not feel well controlled?
Okay.
Okay.
So the question is, how many people were willing to consider deep brain stimulation for something like that? I think that it has been undertaken for severe oromandibular dystonia, in which people have had difficulty breathing, swallowing, talking, similar to what you've had. Some of those patients have had blepharospasm too. And in general, the blepharospasm has not improved as much as the other features. So the evidence that has been to date is that blepharospasm may not be as responsive to deep brain stimulation. And I guess it's because of the fact that people who have blepharospasm, yes, there's problems, potential problems with eyelid control, but still able to swallow and eat and things of that sort. So I think that I would think that for severe craniocervical dystonia, it is something to consider. Until the methodologies are better, I wouldn't recommend it for pure blepharospasm at the moment. The evidence doesn't seem to be there for that right now. That's
Sure.
Would it be possible that some other area of the brain that would help that rather than one dystonia? And that's why
so the question is, do we know the right target? And I think that's a very good question, and I don't think we do know the right target for this necessarily. And I think that that's one of the things that needs to be further developed. There's no doubt, as you heard, that generalized dystonia, cervical dystonia, does pretty well with DBS. Once you get to cranial dystonia, the situation is not at all clear in that regard. I think it's still relatively experimental, and the target, we may not know exactly right what that is. So I think more work needs to be done in that regard.
I have two questions for Dr. Evinger. One is a little tougher. I guess they're both serious, but one. Dr. Evinger, when are you going to cure dry eye for us? That's the harder one.
That falls in my daughter has migraines, and she says, "When are you going to cure migraines?" It's just, I mean, dry eye is again, along with blepharospasm, these are really involve lots of different systems and lots of different aspects of the brain, and it's not like that one individual researcher is going to come along and have some eureka moment and say, "Oh, this is how we fix this." It's going to take lots of different people working on lots of different aspects of all of these diseases to start to put together a full picture. And then once that full picture is starting to get together, then it's going to be easier to figure out what ways to treat these disorders. But I don't think it's, like I said, there's not going to be someone with a eureka moment.
We haven't been able to deal with a common cold yet.
This is another question for you. I hear this from time to time, Dr. Evinger. Can dry eyes be the main cause of blepharospasm? I've had dry eyes for 30 years.
Well, I would argue again, as you know, Dr. Hallett was pointing out, that that can be a trigger for blepharospasm. I mean, if you have severe dry eyes, I mean, you can have this reflex blepharospasm in the sense of it wouldn't be classical blepharospasm. It's just, you know, it's just your eyes are so dry that you just, you know, can't keep from closing your eyes all the time. I think of it as more as a trigger. And again, this issue of, you know, increased facilitation or decreased inhibition. If you think about the trigeminal system, it's all your sensations of that go on in your face, except basically vision. If your brain, if your trigeminal system gets sensitized, even though your dry eye may not actually be a problem, it'll feel like it's a problem because your brain is telling you it's a problem. In the same way that if you think about you get a small burn on your hand, and it lasts a little bit, and then it starts to feel even worse, right? And that's because in your spinal cord, which has neurons that respond to this damage they become sensitized, and so now when you start touching it becomes even worse. So the example would be, you know, you go out, you're normally taking a shower, no problem, then you get a sunburn, right? And you go into the shower, and now it feels like someone turned it on, you know, at 200 degrees, like you're in boiling water, right? And it's just because your brain is convinced it's sensitized, it's cranked up. And so the dry eye is more, like I said, it's how the brain is responding to some sort of eye irritation. It can take on a life of its own, which can give you a very severe sensation, or it can be taken care of, you know, by sort of typical means.
Dr. Hallett, I've heard of a drug called Nevenac to help with pain for photophobia. What do you think of this? It's a ophthalmic ointment. Are you aware of it? I'm not
aware of it. Who asked that question? What is that ointment? Anybody aware of the ointment? I don't see where that would necessarily play a role in photophobia. If it's the light that is the problem, I don't see how an ointment is going to deal with that particular
some sort
issue.
of NSAID for ophthalmic use. So, okay. What is the role of dopamine in blepharospasm? Any new research? Dr. Evinger?
Well, you've done some old research.
I've done some old research.
I've done old research.
The old research was that in some ways you could use a small decrease in dopamine to provide sort of a permissive environment in which dry eye can cause problems. I think Dr. Peterson is being funded by the the BEVRF has been doing some work on that, looking at it more specifically. I don't think that overall that a loss of dopamine is really typical of most blepharospasm patients. I mean, there might be some, but I don't think it's a typical thing.
So in terms of recent work in the area, I would agree that pharmacologically I'm not sure it helps that much. But let me tell you about a little bit new research in this area. Dopamine is a neurotransmitter in the basal ganglia, and it is secreted by dopaminergic neurons, and then the dopamine is received by other neurons that have dopamine receptors on their surface. And there are a number of different types of dopamine receptors. They are numbered D1, D2, D3, D4, and D5. And the D2 receptors are the most common receptors that are in the basal ganglia. There have been a number of studies over the last decade or so that have looked at the number of D2 receptors, and in most types of dystonia, the numbers of D2 receptors are decreased. There have been some recent studies, including some from our own group, that have demonstrated this once again in patients with focal hand dystonia and spasmodic dysphonia that have a decrease in the number of D2 receptors. I believe there's been some work in blepharospasm as well in the past in this regard. Now, additionally, it's possible using a PET technique, positron emission tomography, PET, to look at the amount of dopamine release during various tasks. And this is done by also looking at the influence on D2 receptor binding in certain situations. It gets to be a little bit complicated. In any event, when patients with spasmodic dysphonia speak, the amount of dopamine release is less than it should be. When patients with writer's cramp, focal dystonia of the hand, write, the amount of dystonia released is less than it should be. But when patients with spasmodic dysphonia write, the dopamine is normal, and when patients with focal hand dystonia speak, the dopamine release is normal. So there does appear to be a decrease of dopamine release specific to the dystonia, at least in those situations. So the amount of D2 receptor is diminished, and the amount of dopamine release for the specific dystonia is in fact reduced. Now, one would then think that giving dopamine might help, and that's where we go back to what we said before, but in most circumstances, giving dopamine doesn't help. There are very rare cases in which it does, actually. Some of the time it is beneficial, but most of the time it doesn't seem to help. So even though the amount of dopamine release does appear to be impaired, just replacing the dopamine is not sufficient to help. That may be because the dopamine problem is so focal that just flooding the system with dopamine is not sufficient to be beneficial. Nevertheless, I think this type of work does continue to imply that dopamine is relevant, but exactly how it's going to play a role and how that will translate into therapy eventually is not clear.
Okay, I have two final questions here. First, Dr. Hallett, then Dr. Richardson. Dr. Hallett, I did a mexiletine, that's an antiarrhythmic drug, study with you at the NIH several years ago. My blepharospasm reaction to this drug was very good. The study was inconclusive, I understand. I gave up the drug due to it being a heart medication. In your opinion, would taking this drug be safe for me? Having no heart problems, i.e., would it be possible to create heart problems? Also, do you think mexiletine might help with my recent manifestation of MAGE?
So these issues come up from time to time, that there are occasional drugs that individual people respond to very well, but then when they're tried in large number of patients, on average, patients don't improve. And there was some suggestion that mexilatine was useful for different types of dystonia a number of years ago. There were a number of trials that were conducted, including one that we did, and the patient who asked the question was in our trial. Occasional patients did improve, but on average, patients didn't improve. And this is true of almost a very large number of medicines. It's hard to know exactly why that's the case. In any event, since most patients didn't improve, there was a loss of interest in this particular drug. Now, whether individual patients still could benefit, it still might well be the case, and that is something that would have to be discussed on an individual basis with your doctor, but it isn't something that's going to generally be beneficial. A number of groups tried it, and everybody had the same sort of result, that there might be a rare patient that responded, but on average it doesn't work.
Okay, Dr. Richardson, when sleeping, my spasms, eye, lower face, neck, shoulders all go away. Also, when I have acupuncture, the symptoms go away for 10 to 12 hours. Would it make sense to do MRIs of patients' brains when they're awake versus when they're asleep? Is there any difference? Also, have you seen any remission, even short-term, with alternative therapies like neurofeedback, yoga, running, acupuncture?
I'll address the last one first. This is what I tell patients when they ask me about alternative therapies. I mean, I think what Dr. Hallett said is it in a nutshell, that anything that you can do that relieves stress is going to benefit symptomatology. And we see this across the board in movement disorder patients, so I think that is one similarity between these disorders, whether it's essential tremor, Parkinson's disease, or different types of dystonia. And that probably has to do with overlap between the circuitry loops that I showed you a diagram of briefly, and that these probably interact and can modulate each other to a certain extent. So these alternative therapies, in my opinion, are unlikely to reverse symptoms of a primary disorder to the extent that one does not need other medical therapy if you've reached that point already where you're taking medication or you're, for instance, getting Botox injections. But it's probably going to help, and it's certainly not going to hurt. I mean, anything that you can do that promotes moderate living, exercise, and healthy lifestyle, being thoughtful, meditation, yoga, etc., those things are great. I mean, I would do yoga if I had time to do it. With regard to the question of symptoms going away while sleeping, this sleep, and again, Dr. Hallett and Dr. Evinger know much more about this than I do, but this is variable between patients, but in a number of movement disorders, patients are surprisingly able to sleep. When they're awake, their symptoms come back. Doing functional neuroimaging studies with patients awake and asleep, I think, would be interesting. Those are hard to do. There are other people that study sleep and its relation to different disorders, do measure brain activity, for instance, through EEG, which is scalp recording of electrical activity in the brain with people asleep and awake. But I'd say normal MRI imaging that any of us are likely to undergo during some workup of a movement disorder, it would be unlikely to show a difference between when you're awake or asleep.
Right, I could comment a little bit more on this issue. When people sleep, the brain seems to turn off the motor system. There is a marked inhibition of the motor system. So that's why you're sort of still when you are sleeping, in part because the motor system is in part shut off. And I think it's that reason, to some extent, that a lot of movement disorders get better when people sleep. I'm not sure that it's a helpful thing in terms of understanding what to do for people while they're awake, because, of course, you want to be able to move when you're awake, so you don't want to turn off your whole motor system. But that is something that happens when you are sleeping. I think the very first research grant that was given by the BEBRF was given to John Mazziata for studies of blepharospasm awake and asleep. So it goes back, I don't know, when did he do that study? Probably 15 years ago. And what he found was that the brain metabolism, just as you were saying, the brain metabolism is relatively similar when you're awake and asleep. And I think he found a couple of observations, but they weren't secure, and I'm not even sure that he ever published his studies in the end. Yeah, Mary Lou agrees. So that the observations were not particularly certain, even though the metabolism was relatively the same in normal subjects while they were awake and sleep and subjects. So it has been done, but it hasn't really clarified the situation.
Well,